is about how do we assess chronic pain patients in chronic pain clinics. It might be more detailed. However, I try just to show you the standard benchmark where if a patient comes with chronic pain, this is what they will be expected to get from you. First, we need to understand the concept, the new concept of chronic pain. Chronic pain now is considered to be a bio-psycho-social concept or problem together. So there is a biological, there might be something injured or spasm or disc or whatever, so something physical. Psycho, there is something in the depression, anxiety elements, and social in the circle of the family, loss of income, loss of work, etc. So these three cycles or circles interact together and then give you that state of chronic pain. So your assessment needs to reflect this. And also you need to develop rapport, empathy, understanding, trust between you and the patient. So the template that I will show you, a copy of it at the very end. I'm going to show you the template at the beginning, then I show it to you again and then. Here is the template. There are 4 pages, like this, and like that. So 4 pages will be filled by you or by your assistant for every patient. So we are going to go through these one by one. First, personal information. Obviously, you need to write the name, address, contact number, age, etc. Then, what are the problems? Problem number 1, I have neck ache. Problem number 2, I have back ache. Problem number 3, between these, I get some terrible headaches. So you have 3 different issues that you need to take each of them separately. Each of them, you're going to apply this list. Where is it? Where does it start? Where does it go to? So called radiation. So for instance, it is my neck pain and it goes all the way to my thumb. Then that it gives you a clue that this is a nerve pain coming from the neck. Onset. How did it start? Was there a road traffic accident? Was there injury? There might be litigation. There might be some court cases going on, etc. Duration, how long has it been? Years. Some people come to you and say, since I was a child, I have backache. How old are you now? 40 years old. What kind of disease that lasts or injury that lasts 40 years? It doesn't make sense. So you're going to stop looking for the physical part and you're going to dig into the psychosocial part. What does this 40 years of suffering give to the patient in return to keep holding to it? This is very important when you assess chronic pain patients. Duration, okay. Progression, does it get worse or steady or it's getting better or it has ups and downs? Because if pain has ups and downs, that treatment will be different than if it is a continuous pain. Character, is it sharp, dull, burning, electric? Is it pins and needles? And for those who do not speak English, you must translate these into your own language or the own local colloquial language of the people. If you are going to work in a village, you need to go and understand what do they mean when they say tingling. What is the name for tingling pain in that local area? Because if you miss that tingling part, that stabbing I will give you some clues now. Tingling, stabbing, electric shock means a nerve-related pain. Dull, pressure, kind of like toothache pain, spasm, that usually mean a musculoskeletal pain. There is obviously some exceptions, but this is important clue for you to diagnose sciatica, for instance, rather than just a mechanical low back pain. Severity, you need to put a number or a figure or a picture or a word on that pain to compare it for later on. So we ask the patient what the visual analog score or numerical analog score, what is the pain from 0 to 10? 0, no pain. 10, the worst pain you can think of. What is it now? They say it is 6. Or like birth pain, for instance. The people say, oh, is it like birth pain? You say yes. But you are talking to me. During birth, you are not able to talk. So it cannot be 10 out of 10. Some patients come and say, it's 11 out of 10. And they are laughing and sitting. It can't. This means there is a lot of psychology behind it, a lot of anxiety behind it that makes it feel that much. So you need to get, and ideally, you need 3 figures. What is the average score? When it is worse, what it is, and when it is best, what it is. Aggravation, what makes this pain worse? Sorry, there is some spelling mistake here. What makes this pain worse, and what makes it better? Clues, if the pain is better on a hot bath, or by massage, or by rubbing it, or by hot water bottle, this is usually a musculoskeletal pain, because muscle spasm love heat to relax. If it doesn't, then it is mostly like a nerve-related pain. Ease by walking or sitting or lying down, ease by medication. If it is not eased by medication, then you might like to challenge patient. Why do you take the medication then? It's an opportunity to start that discussion about reducing your non-steroidal anti-inflammatory that you have been taking for years, and they are just ruining your kidneys and will end up with a gastric ulcer. So this, every item of this has got some implication behind it. What are the associating symptoms? This comes especially for migraine. There's nausea, vomiting, sweating, aura, I hear voice, I see lights, etc., etc., with these associated symptoms. These associated symptoms sometimes also give you a clue about what comes next. For instance, if they say, when it comes, I just go and turn the light off and go and curl in my bed. This is very classical of ladies with endometriosis or pelvic pain, who have depression, who start to lose family connection, and they are going downhill in the pathway of depression, etc. So this is important, that you don't want only to treat the pain, you want to treat how do they deal with the pain. Is curling, sitting in the bed with the dark light the only way that you can cope with the pain, or did you try something else? Did you try going out, for instance? Did you try a hot bath? Did you try a bit, and so on? So you're opening other venues for the patient. So you can imagine if you're going to ask all these for each problem, and this is just taking the history of that pain. Next will be you need to exclude what we call them red flags, especially if you have somebody coming to you with low back pain or sciatica. You want to exclude 2 things. We want to exclude that they have what we call coda equina, that is a surgical emergency. It means there is a disc pressing on nerves and that need a surgeon within 12 hours. Otherwise, they might lose their function of urine feces control forever. That is very serious. and the patients with this need to know this. If you feel incontinent, whether water or feces, if you have a food drop, when you wash yourself after toilet, you cannot feel the sensation, take yourself to the nearest casualty immediately. Do not call me. Go there.
6 hours.
You've got 6 hours. I was generous with 12 hours. He is the expert. And your surgeon will tell you 6 hours. After that, don't blame me. Blame yourself that you slept on it, or you went for your holiday, or took a flight somewhere and say, it would be better when I go somewhere nicer.
My question to you and to Dr. Merritt, but 6 hours to be recognized by the patient himself, then the GP, then to arrange for an expert. I think this is too short time.
Yeah.
But we have to aware patient if it happens.
Yeah.
It is complete weakness.
Yeah.
But it does rarely. It can suddenly.
Yes.
You have to talk patient if something happens.
Yes.
Like that.
Yes.
You have immediately to go. Drop foot when hernia is located laterally, or medially it is located cauda syndrome of cauda equina. But we in the beginning we have numbness. Neurological deficit isn't complete.
Yes. I think that the most dangerous word in medicine, progressive. Yes.
So there are other acronyms or things that for people to keep remembering, the 5 Ds, the 3N, or whatever. There are lots of these: dizziness, diplopia, and so on. Some of them to do with discs in the neck, discs in the back, and also others to do with more others of fever and weight loss. This is to do with cancer and TB. These are all the things that you need to be aware. Please do not do hijama on these people without asking further questions and without referring, or at least asking, did you do MRI recently? What was the investigation? What did the doctor tell you before you start embarking? And just having a tunnel vision, oh, it is the back pain, let me put my cups on the back, and then everything will be okay. Because believe me, if this patient goes to a hospital with your cupping, scarring on there, and you are a doctor as well, you will be
licensed.
You will be really trouble. Okay, red flags. You can put this posture in your clinic. You can give it to your patients in the history and in the examination. In the history, any history of malignancy before, because there might be recurrence of secondaries, unexplained weight loss, loss of appetite, recent fever or chills or infection. We're looking for TB or meningitis, immunosuppression, because that will make them more vulnerable for infection or cancer maybe. Pain at rest or during night. This is a little bit overkill, to be honest with you, but as Professor Yusuf is saying, the magic word here is progressive. It's getting worse. It is not the usual that I lived with for years. Any trauma? Did you fall recently? Many trauma do not produce the immediate effect straight away, but then you go home, you start to find the numb leg or the numb arm, and so on. Recent onset of bowel or bladder dysfunction. There is incontinence, or you wet yourself for the first time also. Physical examination, progressive neurologic deficit in the lower extremity, saddle anesthesia, anal sphincter weakness, and fever. So be aware of these. Have them as a poster in your clinic. Might be a good educational tool. So when the patient's sitting, waiting for their turn, they look around and they say, oh, this is good. I take a picture, and it kind of sink in their mind that they learn something new. It might be handy later on for them. Then we are going to assess mobility and function. Starting from asking, obviously, starting from looking at the patient walking towards you, and we will talk about this later, but you ask the patient, are you able to dress yourself, especially with shoulder problems? You say, I cannot comb my hair. That is very important. Even before you examine the patient, you know that there is something wrong with the suprascapular bursa and supraspinatus area, etc. Unlike a frozen shoulder, that the whole shoulder is not. It's that particular movement, head above the hand above the head is the main issue. I cannot reach for the kitchen stuff above my head. I cannot wash myself again. Activity level, how far can you walk? How long can you sit? And mobility is, when you walk, do you use a stick? Somebody might tell you, yeah, it's the first time I start to use a stick in my life. That is a significant finding. That means there's something maybe wrong with the balance, the muscle tone, and it gives you all the time clues about what is going on and how progressive it is. Then you need to ask about their sleep. Very important, because as we said, it's not just the pain, it's the whole patient. Some people say, I can manage the pain during the day because I get distracted. But it's the sleep. I would just like a decent 4 hours sleep. If you can give me that, I'll be very grateful. So it's a sleep issue. Then you need to talk about sleep hygiene. What do you do before you go to sleep? You can have a cup of tea. Is that a good thing? Or some people have a cup of coffee and then go to sleep. What are you trying to do? You're beating pharmacology or defeating science. Or some people open their emails and their messages before they go to sleep. So get all excited. All the bad news of the day happen just before you discover it while you're going to sleep. This is not the way. So you need to prepare your body for sleep. There are talks about sleep hygiene that even leaflet you can give to the patients if sleep is the issue. Sleep might be disturbed because of water work, not pain. This is a prostate problem or cystitis or something else. You need to ask about these. Past medical history, as Professor Miller was saying, did you have laminectomy before? You have disc operation? Did you have disc protrusion before? Did you work in heavy work? Did you injure yourself? Also, all this past medical history, cancer is very important because of secondaries, especially cancer of prostate is very, very important and very nasty in secondaries in the lumbar area. Medication, current and previous medication. We need to have a list of medication, with the current medication, the doses, the frequency, that again give you an idea how the patient think of their pain. Some of them become like a walking pharmacy. They have a bag full of medicine, and some of them are similar. Naproxen, Brufen, aspirin, all the same almost. Why you combine all these? Tramadol, cocodamol, and maybe fentanyl patch, and oromorphin at home. We have patients like this. Our battle is not to treat the pain, is to tell them how toxic they are taking, the toxin they are taking themselves. So obviously, previous medication, it is so embarrassing when you are a doctor and say, I've got a nice tablet for you. Have you ever, here it is, and then the patient look at it, gabapentin, I had it before, it didn't work. You need to ask this question before volunteering the treatment. Allergies, very important. Allergies, not only, I want to relate this to the hijama, allergies could be to the skin cleaning stuff that you use. Some people will tell you, I am allergic to dye, to the dye. I had kidney X-ray with the dye, and I nearly died. The dye contains iodine, and you are going to clean the skin with iodine. So you need to be careful. Do you want to risk that, or you want to find a substitute? So you're going to use chlorhexidine or alcohol or whatever. So you need to ask about allergies as well.
Actually, it's an amazing event because really in Egypt 2 weeks ago we had a case of fluorescein dye for eyes. It's very rare. I think one every 200,000, and the patient was young lady and she died. So taking a history of allergy should be our habit.
I can imagine the story.
Yes.
A patient died
Yes.
after eye drops.
Yes.
Allah Akbar.
حاجة كارثية. Catastrophe actually.
So don't take allergy lightly. Investigation, you need to know if this patient had X-ray, MRI. The clue is there in front. It is not in front of your eyes because you cannot see it, but it is in the patient pocket. Just get them to produce the report. Let's say they have a disc on L4, L5. Half your job is done. Okay. Previous interventions. We talked about previous medication. Did they have physiotherapy? Did they have any mental health issues? Were they under psychiatrist before? They might have schizophrenia. They might have bipolar disorder. They might have chronic pain patients. Third of them have psychiatric problems. So you need to be very careful when you deal with these patients because you are not a psychiatrist. So you're not trained to look at somebody in the eyes, and I don't even psychiatrists can do this. Bipolar patients, schizophrenic patients are very intelligent, very deceiving in their appearance, and they cannot reveal what they have, maybe till they are either missing their medication or under severe stress. So they might be sitting among other patients in your clinic and no sign of whatever. But once you start to talk about treatment, future things, you will see all the negativity, all the criticism, all the complaint, all the anger inside about the medical establishment or previous encounters with previous physicians, etc. Other previous treatments. Be careful, patients come to you even for hijama. You need to ask them, did you have anything else? Because they might have been shopping around. They might have just acupuncture the day before, and then hijama today, and then hijama from your neighbor next door, and so on. So you need to be asking about these things, not to be blamed later on for other complications from other people. Then we talk about the social aspect. Do they play sport? Is it something that can help them to get over their pain or depression or masking this pain by having some social activities? What are their coping strategies? Sometimes I ask patients, especially those who do not work. Okay, you have pain for the last 5 years and you have not worked for 10 years. So you're sitting at home 24 hours doing what? Thinking about your pain. What kind of life is this? So if you want to try to take your mind off your pain, what do you do? They might tell you, I watch television, I used to do fishing, but now I stopped. I used to have a friend walking and so on. So you start to tap onto these things to give them some motivation. What do you understand about your pain? Some patients say, my mom was on a wheelchair, and I am now nearly her age where she was on a wheelchair. So I am trying to buy the best wheelchair that I can afford because history repeats itself. But you are not your mother, and your mother lived 40 years ago. Medicine moved long time. Why you are? What is your understanding of it? You say back pain is running in our families, or arthritis. I am just waiting my time to be handicapped or disabled. So you need to know, or I have a disc, but you look at the MRI significantly saying everything is normal. Who told you that you have a disc? Maybe there was somebody who misinterpreted the result or was mixed with somebody. So you really need to understand what do the patient, do the patient understand or know about the illness. Also, what do they understand by chronic illness? What do you understand by chronic pain? What do you mean by chronic? It's something that is not going to go away. Do you understand that? You and I understand about diabetes, hypertension, that once it visits you, it doesn't leave you. But some people think chronic pain is just like a toothache. I go to the doctor, he take my teeth out, pain is gone. So I'm coming to Maren, he's a pain doctor, or he think hijama is good for pain. So very much like the dentist, I need to be pain-free on the door outside. Otherwise, I'm going to complain and give him bad name.
Expectations, yes.
What is expectation?
Yes.
We are called pain management, not pain treatment. So we manage, we help you to manage your pain, to live with it, to understand it, to get the best out of life while it is still there if we cannot take it away. Expectations, what is the patient expecting? This obviously, patient will come to you for hijama, expect hijama. But in the bigger picture, they expect in a chronic pain clinic more tablets, injections, further investigations, referral to other doctors, referral to physiotherapists, psychology referral. What is their expectation and what do they don't want? Some patients say, I will not talk about my pain. So they shut the door of any psychology.
Yes, they asked you, Dr. Hussein and Dr. Miriam, about an example of this, like migraine. Migraine, this is some sort of chronic pain, and patients are accustomed every now and then to have this attack and or and so on. What you will say to a migraine patient, and what you will tell the patient that most probably after hijama he will be relieved partially. I mean, for you as a pain consultant, and for Dr. Merit as a hijama senior.
In the pain clinic, when we have something like this, we like them to give us a diary.
Sorry?
A diary.
Yes, he write
Down
down
the diary,
Yeah.
how often
Yes.
over the last 2 weeks,
Yes.
show me how frequent your attacks, how long do they last, and how severe they are.
Yes.
So I have a solid evidence of your problem before.
Oh, yes. Before-
Okay,
Then
then we're going to do whatever we're going to do,
Yeah.
and then you bring a diary
Yeah.
for the next 3 months or 2 weeks or so.
Yes. Yes.
So when you tell me your treatment did not work,
Yeah.
I can compare,
Ah.
or did it work? I also can compare, and I don't promise that. Don't worry, your migraine is my problem now. I take it on your back. We don't ever promise patients anything.
Yeah.
Never promise patient anything.
Yeah.
I play the game ping pong with the patient.
Yeah.
Patient tell me, ask me,
Yeah.
doctor, is it tablets, physiotherapy, or the injection? You told me all of them.
Yes.
What do you think of it?
I don't know.
Exactly. But you are the doctor.
Yes.
I come to you for advice.
Yes.
I tell them, I give you choices.
Yes.
To choose from. I'm like a window
Yeah.
shop. You come into the window, you choose what you want, you pay for it, not the seller. Don't let the seller
But
force.
it's your role to tell him science is saying that there's 20%.
Exactly.
And even you may be the 20% failure.
Exactly.
So-
I give you information, facts.
Yes.
I don't give you emotion, and I have to be emotionally out of it.
Sure.
Otherwise, I will get crying.
Yes, start with him.
Okay. Then, because if the patient comes back to tell you, doctor, your injection didn't work, what will I say?
I have told you before.
But that was your choice.
Yes.
Tossing the ball back to me. It's a ping pong.
Yes.
If you don't do this,
Sure.
you end up after seeing 3-4 patients who are blaming you for failure, you will need a psychiatrist after that. So I don't know.
My choice, usually people take the diagnosis as part of themselves. They're very attached to diagnosis. Just for example, people after 40 years old, 80% get low back pain. It is statistic. And when such person underwent MRI, it is normally to have degenerative process, including on disc. And bulging disc or protrusion is kind of disc herniation. And they come to you and say, I have herniated disc and problem with that. When you examine patient, he has only lumbar back pain, no connection with disc herniation and pressure on the SCR. In migraine, it is maybe simple. Severe headache can be considered a migraine. It doesn't matter which diagnosis patient have. It is important what symptoms he is suffering from. In such case, I have my book when I put headaches and migraines. The start point was because Prophet Sallallahu Alaihi Wasallam was doing for headache.
Yes.
On our symposium 16 years ago, professor of neurologists are dealing with the headache and the migraine. She spoke about how could we explain some mechanism of action of hijama. So I have in my database, but I put on paper. So I said, okay, I have 246 now. Severe headaches, including migraines. They had improvement, and some of them released pain completely. And that is statistic. How it will be to you, it's not up to me. Allah can help, but this is statistic which say a lot.
Sorry, my question, sorry, it's just out of this context. The sites, you've 3 sternal sites and 1 here.
My sites are on 7 cervical, please, going down a little bit, and between scapular region, that spinal scapula here, is on the lowest part of cup is on 7th right skull. And it goes maybe up 3 points. So it is between scapula and on the neck, and it really is.
So only 3.
Yes.
But no need for a lady to shave hair and put one on the.
No need completely, because that can do everything. The only thing is when headache is located in one place. For example, by which point, which Chinese say, and our language say, we said, so up on my head. Then we can put a local point. My idea was that the Prophet Sallallahu Alaihi Wasallam show us points, and this is like interface to all regulative system. But if he suggests also some local points when local problem appears.
Okay. Thank you.
What about medical background? I mean, 1 point to have a headache, would that be medical? Because it's very rarely that it's only 1 point.
Very rare. So I'm telling that like example for some exceptions. So almost all headaches released with 3 points.
What could that be underlying cause, medical cause, to have one place?
Usually here on occipital region, it's because cervical spine.
Yes.
So
what about this?
then I use 4 points this side. Here 2 points on this region.
Do you recommend CT or MRI if it's something unusual and rare like that? Can it be connected with
Usually
unusual?
patient with severe headaches and migraine, they went to the neurologist, and there is protocol to see if there is underlying organic problem like tumor or something.
So it can be tumor.
Yes. Especially in morning, brain tumor gives morning headaches with vomiting or nausea and symptoms. Sorry, we interrupted.
Okay, so we stopped at the patient expectations. Then you need to also ask about other stresses. Losing job, moving houses. We have patients usually come to pain clinic only because they cannot climb stairs anymore. And there's really reason to come to a pain clinic that they want. I'm talking about UK experience. They want something to help with the council to enable them to move to a ground floor flat. That is what the agenda.
Secondary benefit.
Yeah, but that agenda doesn't usually come up except while they're just leaving the clinic. So the whole hour in the clinic is the cat and mouse game. Where is your pain? Here. Okay, how does it go there? How long there? Okay, you treat this. And then, yeah, we'll refer you for visitor. I tried visitor. It didn't. Okay, what do you think about injections? Tell me about it. You spend 15 minutes explain. No, I don't want injections. And so on. Tablets, I tried this one. That made this. And when you are about to say, look, I cannot offer you anything else because you had everything. They then on their leaving they say, so you cannot help me then to move to that flower because the stairs is killing me. Where should I go to get? Where shall I go to get support for the social council? So this is why you come here. We don't deal with that, and then so you need to know what are the other stresses as well. Now this was all history taken. Now we are going for the physical examination. Same classic inspection, palpation, with percussion is going to, and then auscultation as they teach medical students. But for pain, I think we don't do lots for auscultation unless you think there's back pain because of aortic aneurysm, then you need to do something about it. And this is where the more medical knowledge you know, the better. Inspection from the way the patient is walking towards you. It's very important to see the patient walking. How do they walk? Do they have antalgic gait? They are limping, they cannot touch the floor with one limb. Do they taking big deep breaths, lots of sighs, lots of what do we call them, pain behavior, that they want the whole world to know about their pain. That is their agenda, as we said, secondary gain. So people around them keep helping them and giving them all extra support. Posture, how the patients stand, do they have kyphosis, scoliosis, neck problems, etc. Muscle wasting, tremors, especially those for Parkinsonism, also because of the tremors and the muscle spasms, they have lots of back pain, swelling, redness in any of the joints, particular joints, blood vessels, especially if you're going to do hijama, you need to look where is your cup going to be in relation to this very superficial way. If you like, I don't like to do this area, but if you're going to do, some people have tortuous veins here. You are really looking for trouble to put a cup and then do the scratches and then end up with massive bleeding. Palpation, you're going to touch the area just to elicit, can I touch this area? So some people have super sensitivity, so they will tell you, no, don't even touch it because I cannot even wear clothes to cover this. Tone of the muscles, reflexes, trigger points. Important part about trigger points because most of our hijama will be after what Professor Mariam is saying, the al-kahil wal-ukhda'ain, these three classical points. the trigger points. Where else does it have? The local problem. It's my lower back, or it's my knee, or my thigh, whatever. You need to elicit trigger point. Its trigger point is elicited by a decent pressure on that point, on that muscle. You're palpating with pressure, not just superficial touch. And that needs training, because if you do it very gently, you will miss all the trigger points. And if you're very vigorous, everywhere in the body will be triggered. So you need to gauge it to the size of the patient, musculature of the patient, and so on. But there is standard. There is the best thing really. Go to your kitchen. You get the scale that you weigh your flour and sugar and so on, and put your finger to get between 2 and 4 kilograms. So push the scale to show you 2 to 4 kilos, and that is the amount of pressure you need to put.
Very nice tip.
Yeah, this is very important. We teach this to our anesthetic technicians to do cricoid pressure. So this is a bit of diversion, but cricoid pressure, you press here while you are putting the patient to sleep to squeeze the esophagus between the cricoid and the backbone. So if the patient regurgitate, any soilage from the stomach does not go into the lung. This is a very skillful training, and if you don't do it right, patient might die after inhalation. So how you do it, you take them to the lab and you put them pressure to show me 4 kilos.
Excellent.
Yeah, so this is very good. And everyone has got a scale in their home now to be able to,
Using the thumb or the two.
whichever, whatever you're going to
Whatever,
use,
yes.
usually I use my thumb
Yes.
to elicit trigger points, but if you're going to use 2 fingers or you're left-handed or right-handed or whatever, you need to use it with the fingers you're going to use. Okay, be careful with trigger point examination. I put here a link for a video on a YouTube. You might be able to watch this. And there is major trigger points. Trigger points, if you know your anatomy, you know to look for them. Some patients tell you, oh, you're spot on. How did you know that? I know this.
Since 40 years.
If you tell me there is a pain in my shoulders, it's either the trapezius or the infraspinatus. So I know where is the trigger point. So my hand will be straight onto the point, maybe a millimeter here or there. But they in this diagram. Finally, be careful of the fibromyalgia. In Arabic, it is called متلازمة الألم العضلي الليفي. It's a very long word because fibro is a word, myo is a word, algia is another word. So in Arabic, it's to come in 3 words, and متلازمة means syndrome. It's a syndrome. These are the points where we used to elicit fibromyalgia, 18 points. We don't do this anymore now. We used to count. Press here, there. If you are 14 plus, you are fibromyalgia. If less, you are called myofascial syndrome. Or if you only 1, then it is called a trigger point. But the reason I'm putting this, fibromyalgia patients will have trigger points all over their body. So no matter where you press, they're going to say, yes, it is painful. Even here, look in the manubrio-sternal joint. This area is almost never tender. This is a clue for you. If you want a very quick clue, is this patient fibromyalgia or not, just press here. If they say, yeah, it's painful, don't waste your time looking everywhere else, because everywhere else will be painful. So it's just a short.
If you just press it.
And if you press and they say it is painful,
Yes.
then it is fibromyalgia. It's going to be widespread body pain.
So it is like for the surgeon, the left, but very
Exactly.
for
appendix, or to exclude yes or no.
Yeah.
Then you can relax for the rest of the consultation. Yeah. So after that, you're going to put a plan. You're going to. This was just the assessment. And these sheets that I showed you, all these sections that I talked to you about are all in here one by one. I don't know, it's in this screen, maybe in a computer might be better, but by all means, you can copy it. It's not copyright, it carries the name of our hospital, but by all means, you can use it. Some people like to draw a map of the body and then mark where exactly the problem rather than writing down. And then you can refer to this after years. The patient might come in 2-3 years and say, yes, you came to me last year, it was your right shoulder and under the scapula. Oh, now it is your left shoulder. Oh, yeah, I can't even remember. And you have the documentation for comparison and so on. So these are the two that I started with, and it's the back part. Then after that, you write your impression, what investigations you're going to do, what will be the plan, medication, etc. So this is I'm giving you the feeling of a chronic pain clinic. You need to adapt it to a JAMA clinic, but the first part of assessment should not be less than what we do in chronic pain clinic if you have a patient coming to you for chronic pain. So in summary, we just remind each other with the psychosocial 3 circles. Don't just look at the pain with a keyhole vision. Look at the whole patient. History is very important. British medical training used to say history, 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 because nowadays we are too much relying on investigation. All teachers of ours will kill us if you miss something from the history, and it is always give you a clue that the investigation will jump and you will not go back to again. Then examination, then diagnosis, agreeing a plan with the patient. You can agree, look, we're going to do, let us say we're going to do dry massage cupping first, just to get you to use to the suction and so on, because patients do not, and many times I put the cup on my hand. Some patients never knew anything about cupping, so they have no idea. So you need to start gently, put the cup on your hand, do the suction, show them the redness in your hand. This is how, show me your hand, do it, and how does that feel? Can you tolerate this? Okay, it will be just like that, not on your back. Okay, and then maybe that would be exactly. That's
Especially with children.
yeah, absolutely.
Show him,
Yeah,
let him.
let him even do it to himself.
No, first to yourself.
Yeah.
Then to himself.
Yeah.
Then I told him, this is what I will do it on your back. Believe me, and never cheat a child.
Yeah.
Not like
Yeah.
I said, it will stay on your back. Then we try. Then we try. Like left it in room when we take examination. I leave it. It's uncomfortable, and I said, okay, this will stand some time. Then I will move it. Then I take the solution. I said, this is like chocolate. I put it for disinfection, it's cleaning, and then I do like this on his skin to produce him pain. And say like that, you will feel pain, but only when I tell you straight. And when I start, I said, breathe, it's normally. Now, pain, do it, and then stick with it. It's finished. Okay, can we do it again? Believe me, small children, 5.5 years. Second time performing the Java, she didn't say nothing. But her mother, on the next bed, the child said, mother, what's wrong with you? But any patient is degradation on child level when he is in front of doctor. He needs to be informed what is going to happen if he didn't see it on TV or something.
So you agree the plan as we explained, you just show them the instruments, let them play with it or try it on themselves or the relative or whatever. And then once they are comfortable, then they are going to do it, or you're going to do it to them. And make a plan. Is it going to be one session and then expect results? Or don't expect results for another two sessions or so. Just be open and frank with them and give them the full plan. Don't give them information drop by drop, because that it could be okay for you, but could be very annoying for patients. Patients want to know what's wrong with them, what's going to happen to them, and what is going to be the solution if all the if scenarios. Documentation for further reviews, research, litigation. So you must have a filing system, either digital or written. Obviously, in UK, if you do this, you have to join a membership of a company. You pay them, they give you what you should do for security in your house. Because if you keep files of patient information in your house or office, you have to have security, you have double locks, you have to have phone numbers, you have to have insurance, you have to this, that, because this is obviously a governance issue, and you're not to show them in your mobile, etc. Big issue here in Europe and Western countries, but you need to be having your own system that works for you. So the patient comes, you don't spend hours trying to find their old notes, or they tell you something that you haven't registered. It's very embarrassing. If they come to you 3 times and you only register once, they immediately pick up that you are not a professional. Okay, I think this is the last part of the presentation.
Wonderful, really. Thank you very much. I have a question actually to you and Dr. Merrin. You show what you call the back of a lady or a patient, and this what you call make some sort of stimulation to me, because in my very little number I have done I was not considering what we call it in surgery, and especially plastic surgery, Langer's line. You know, Langer's lines, they differ from the back to the front to face and so and so. And me myself, I was making just vertical, but on the back it is horizontal. What I will just show you now this, and I will ask, yes, here it is. I will just show it to you. For example, okay. Yeah. So you make your scarification like this vertical. I want to ask you to
What is?
This is, yes. This is what you call the lines going with the fibers of the fibers.
You have to follow lines, especially here.
Yes.
Some part if you put cup, and sometimes you follow this line and this line, so it doesn't matter if it looks
vertical or
nice
horizontal. No. The point. You think it will differ if you make a cup, for example, from the back, and make scarification horizontal, or it should be vertical. This is a question, because I'm actually I have never worked except a few months in plastic surgery, but I know that these Langer's lines are respected whenever, for example, you are excising lipoma from skin, even opening an abscess, to get the best cosmetic results. So this is my question for you, what you do and what Dr. Merrin.
I think we're talking two things. We're talking plastic surgery versus scratches.
Yeah,
A plastic surgeon will go through the whole skin.
Yes.
Whatever you excising, you
Yes.
are going through dermis, subcutaneous tissue,
Yes.
everything.
Yes.
Here we are talking about 1 millimeter thick, so it doesn't matter. It's like asking you when you shave. your beard. You don't shave your beard. But somebody shaving their beard, are they anxious about the way they shave in case they scar with a cut? How ugly the cut will be? They shave the way the hair grows, and again, to get the best shape. Scarring with hijama, I don't think is, but it's relevant as with
Yes,
plastic surgery.
sure, it is not relevant, but we can ask the question the other way around. Is you think if you make horizontal scratch, this will affect the amount of fluid type? I don't think.
That's another
I'm
study.
not that
It's
expert.
a study need to be done, because believe me, no, as far as I know, I don't think people who do hijama know anything about plastic
like
surgery.
design.
Yeah, but just I'm following. I also didn't think about that lines because it's not a long scar, but follow normal way of behaving of skin.
Yes.
If it goes like this, you can
Like
follow
this,
it.
it's called the tension lines. I mean, if nothing will differ, if you make it vertical or why not bury
Yeah,
the tension lines?
If fibrous tissue goes like this,
Yes,
and you make scarification
Yeah.
in this way, you can by suction get outside. But
Yeah.
if you go like this, you
Yes.
cannot perform the same.
yes, okay. Maybe actually to be accurate, it needs some sort of research.
Yeah.
Yes.
So when we get patient came here, just an example how I do it. When patient came here, one lawyer suggested me one time ago to put his signature to read that he is.
This is a consent?
Can you please just make a photocopy or just
I have an empty
show
one.
to the people
I have an empty one online.
to the camera?
I will.
I think
It's an embarrassment though. So.
واضحه كده بالنسبه يا محمود؟ دكتوره خلود واضحه كده؟ دكتوره اروع معانا؟
يعني ما
أيوة.
دكتور مريم wants to share his called history or the documentation.
Documentation history, signature, and that he said that he's informed enough about procedure, about possible consequences, and he put signature and date of welcome. This is for me. Sometimes patient to put marks as Dr.
Dr. Miriam, actually you can shoot it with your camera and send it to me. Then I will put it to the participants.
Okay, this is just an example.
No, just photocopy and we
Okay,
put
I'll do it
on
after.
the group and we put it on.
After that, I put European question with 5D questionnaire because of how the movement is standard questionnaire, quality of life, and here's visual scale of well-being, which is measurable when they come next time.
I meant to say, when it comes to assessment of social and psychology, we used to have HAD score, post-traumatic anxiety depression score. Now we do EQ5, EQ9, or EQ. It's called EQ9 and something else. They replaced the HAD score by something more modern, and but during COVID, because most of our consultations were over the phone, we stopped doing that. However, it is important to have something, especially if you feel the patient is dramatizing, catastrophizing, tearful during consultation. You really need to dig a little bit deeper into that psychology and have some document scoring system of some sort.
Scoring just to see how they feel.
If you're going to do this, you really need to translate it into your own language and the translation need to be validated by a study. To be scientific, if you are going to translate that had score into Arabic, then you need a psychologist to run that translation and produce similar results with it to the English one in English speaking to say that this translation is validated translation and becomes the authentic translation, not your own personal translation. Otherwise, you will make mistakes.
Thank you for your suggestion. This is translated on many languages officially, so I just download. Also, there is comparing to last year. Did they feel the same, worse, much worse, or a little bit, or better? And then I use one scale, global impression scale. After that treatment, how they feel. It is translated on English and another language. It is used in some studies. So it means to me what patients say after treatment, so I can score it, compare it, and so on.
So,
And then
this is in English or in Bosnian?
this is in Bosnian language.
Okay.
But the question of life is updated with more specific questions. And this is on Bosnian language. We had the database from the almost beginning. I used to put my questions here about patients. Can I share this or something? Is it worth sharing? Yes. What do you think?
No. Yes. Now
It will share, but I don't know. It's what is just my personal.
Yes.
So I put all data about patient when he was born, when he lives, telephone numbers, how height, tall, heavy, weight, before diseases, past diseases, operations, does he smoke, family anamnesis, all diseases, and then it comes to anamnesis and status. This is
What program was this?
I made it for my clinic.
Access or?
Access, just a very simple access. In fact, I need in my clinic 25 years ago, after war. Neurosurgery deals with very often situation when you have to decide in this moment. And all files were in paper, pictures everywhere. So I need something to have it. So my friend helped me to make this relational database.
Yes, you can see the icon of Access is a very useful tool if you want to design something like this. It needs a little bit of work harder than spreadsheet, but it produces you things like this, that any of these tables, you want to produce a curve or statistic analysis straight away. Like for example, how many of these smokers, you can straight away find out how many about that. It's a very strong program, but needs perseverance to learn how to design your own access tables first. What are you looking for?
Relations. The relations. Yes.
Yeah.
There are people who can make you access table
Ah,
very quickly
right.
if you give them relations. So it is very complicated, but here we have main troubles, anamnesis and diagnosis. I put all diagnosis in from table of the diagnostic table of official. So this is status, temperature, everything here. Psychological status. So it is very useful. More than 19,000 patients. It's here. It's still available on PC. You know, not big one, but we can do everything. My friend helped me, and I think we can share this.
Yeah. This is a treasure.
Status.
Really treasure.
Now, yes, neurological status.
Need somebody
Slow.
to sit down and analyze it.
Startup, yes. I need
You
to
can get at least 5 papers out of this data,
just
that
for,
we analyzing.
and for new patient,
You can even, I can even think of one, educated versus non-educated people coming for pajama clinic in Surrey.
yes, I have level of education here.
Here is one paper.
Level of satisfaction,
Yeah, so many.
follow up, yeah. How many one came for how many one take more than one session? No,
The
a
volume.
lot of ideas. So you young doctors,
And see this,
yeah.
I put new patient. Yeah, it is patient ID. I did therapy 90,080 patient. You said yesterday that you
So I missed
didn't believe. And I asked, what's this? Why it is so?
Oh, no.
I didn't calculate. So I was fascinated with your calculations. 90,000, yes.
Over how many years?
First patient in database is in 2008. When I was in Switzerland, for example, I didn't have time because I was alone. Maybe some 300 there, over there, 500. It doesn't matter. But in database is my first. This is older version, and this is what I use in my computer. The older version is this. And this is my first patient. He is a professor of IT in Mostar. What is his first date? Please tell me.
19th of January 2008.
And then we started with him. He's professor of IT technology in Mostar. And he was my first database. So 14 years. And now it is useful. Now we don't speak about hijama from our beliefs. So
Yeah.
in 2000, I said, by our data, evidence, we have how many patient improvement like this. Excellent, very good or good. That is something. So try from the beginning to collect the data. It's my suggestion. Because time passed and now I see, and the doctor just said, told me that it is very,
Too much.
yeah, not very much interesting. But always have something like this to follow up your patient. So that's it. When we speak about pain, usually when we see that there is everything normal, no organic reason for pain, we don't have many pain consultants here, unfortunately. It will be a real address to send. Usually doctors from here sent to psychiatrists and they said it's all in your head. I said if it is psychological problem, we cannot divide it from ourselves. We are multi-level living beings. And for example, organic pain of discus hernia, I find out that people suffer 10, 20 years, but in one moment they came on operation. I exclude trauma. What happened to that person to come to neurosurgeon to operate it? And with his father is my excellent friend from for over 30 years. He's a psychiatrist. Is it something is happening? Okay, this because of this termination, 90% of them, if you search carefully,
Dr. Merem, please.
some period before that,
The,
he feel yes,
Dr. Merem, the sound.
that
You need to higher your voice.
higher.
Yes.
Okay, 90% had some problems, big problems on work or on in family.
Social or psychological.
Yeah, but when we are under pressure, under stress, under big stress, you try to stay straight. How you say it in Arabic?
واقفا.
على الصراط المستقيم.
When you put your rows on salah.
صح.
تعديل
مستقيم.
عادل عادل
معتدل.
عادل.
معتدل.
and Adu is also right.
عدل.
Adu, not only straighten. You have to straighten yourself, and injustice is something with opposite. Adu is justice, and when people feel unjustified treatment in their life, they try to stay straight, and these paraspinal muscles probably. Yes. Should we make a break a little bit?
Yes, please.
Yes, please, Mahmoud. Thank you. We want to take a break.